From Stockholm, Sweden, this is CardioSource video news coverage of ESC Congress 2010.
Well, it's Monday here at ESC, and we have more clinical trial updates. And joining me here today is friend and colleague Dr. Deepak Bhatt, who also Associate Editor of Clinical Trials on CardioSource, who today presented the final 4-year results from the REACH Registry. So Deepak, do you want to remind us who's in the REACH Registry?
Absolutely. So initially, approximately 69,000 patients from around the world were enrolled in the REACH Registry. These were stable outpatients, primarily drawn from primary care practices who had atherothrombosis. And by that, I mean really the full spectrum of atherothrombosis, ranging from patients with multiple risk factors but no evident atherosclerosis, to those with stable atherosclerosis, and by that I mean, for example, a patient with stable angina and known coronary artery disease, perhaps a prior revascularization, to patients with actual prior ischemic events, namely a myocardial infarction or stroke. So the full spectrum of atherothrombosis was enrolled and followed for up to 4 years.
Well, this is really a unique registry with outpatients, and you focused on who are the high-risk patients. Who did you find were really the highest risk patients?
Exactly. So among those different strata of patients that I mentioned, the highest risk patients were those with prior ischemic events. That was followed by patients with stable atherosclerosis and those with multiple risk factors. That's pretty intuitive and not surprising. But overlaid on that was the contribution of polyvascular disease, which really refers to having vascular disease in 2 or 3 arterial territories. So I'm not talking about multivessel disease and multivessel coronary artery disease. I mean disease in the cerebral circulation and disease in the coronary circulation, or disease in the peripheral circulation plus disease in the cerebral circulation, or all 3. So polyvascular disease was the most powerful predictor of future ischemic events. Diabetes was also a powerful predictor, but interestingly and discordant from prior studies, patients with diabetes without prior ischemic events were at lower risk than patients with prior ischemic events but without diabetes. So unlike prior analyses, diabetes in and of itself was not an MI equivalent. MI was an MI equivalent.
You know, it's a key point that original observation was pretty old, potentially. Yes. Now with the aggressive therapies that, that's fortunately not as high risk. And then what about timing of the event?
That's a good question. Another insight from the analysis of the REACH 4-year data was that patients that had an ischemic event, in particular in the past year, were at much higher risk than those that had a more remote ischemic event. So the real powerful predictors of future ischemic events were polyvascular disease, certainly diabetes, and having a prior ischemic event, but specifically in the past year. Even if it was more remotely than a year, it still carried a fair amount of risk, but in particular that very high risk was within the first year after that ischemic event.
Well, this is terrific. I think the simple list of the 4 characteristics will really be useful in sitting in the office trying to sort out as to who do we need to get more aggressive and think about more intensive therapy. Do you see this as something that clinicians could use day to day?
So our hope from the whole REACH group was that this would be useful to clinicians in daily practice. Of course, there are ways of risk stratifying patients in the primary prevention universe. There are ways of risk stratifying in the ACS and heart failure universes. But for secondary prevention, in general, the thinking has been, well, give everybody a statin and aspirin, and I think that's good advice. But within that universe of secondary prevention, what we've shown in this analysis is that there's really a large variation in risk. Patients that have had a prior MI or stroke in the past year are at exceedingly high risk of a recurrent ischemic event in the next few years, whereas patients that have multiple risk factors or even stable atherosclerosis but have not had an ischemic event are at much lower risk. So there is a difference in risk in secondary prevention, and I think that message is an important one for clinicians as they try to target the most intensive therapies to those at the higher end of the risk spectrum.
Well, it's terrific information. I think having the final results from REACH really can be clinically useful, so congratulations.
Thank you.
So from the ESC, I'm Chris Cannon for CardioSource Video News.